Hello, it's lovely to be here. We're here today to share the work we've done based on recommendations in the ENSPOD report On the Right Track. Just share our journey really from 2014 to the present day. So who are we? We're Ward 9 at Moseley Hall Hospital, and it's a 24 hours a day, 7 days a week service, specialist level 1 Neuro Rehab unit. We're part of the West Midlands-wide specialist rehabilitation service, and the patients that are referred into that service have complex rehabilitation needs, and the case mix also includes a number of patients who have complex tracheostomies. As a wider trust, we're also responsible for patients in the community setting who have similar needs. In terms of the national picture, the ENSPOD study On the Right Track was published in 2014. And it identified that nationally the care of patients with tracheostomies was a concern. From 2005 to 2007, the National Patient Safety Agency reported 5% of airway incidents related to tracheostomies, and in the report it indicates that actually the number of incidents is underreported. 14 of the incidents were classed as major or life-threatening. Locally, as a ward, they were admitting more patients with tracheostomies than they'd had previously, and local learning from an incident out of hours highlighted just how important it was to have staff with the correct skill set and access to the correct equipment for these patients. Our key lesson here was we needed this at all times, especially out of hours. Within the ENSPOD report, the recommendations were grouped around a number of themes. I don't plan to go through those individually, as our later slides will touch on the work we've done in these areas, but these are there just for information. So, as an ENSPOD local reporter, the report arrives in your inbox, and what's really important here is to think about, well, who do I communicate that report to? What are the key recommendations, and what does this really mean for us? And where do I go next? So what we did was we shared the report and the key recommendations widely for our Trust Clinical Effectiveness Committee, and considered which services these recommendations would really apply to for us in a community setting. We identified an opportunity for joint working between our specialist rehabilitation service and also our adult inpatient services in the community hospitals. And we established a joint multidisciplinary working group to ensure we've got a really clear trust-wide approach and a work programme in place to respond to these. So, a bit of the previous presentation, we started with our policy. So in 2014, we developed a new tracheostomy care policy, and the aim was to provide staff with comprehensive, up-to-date and specific management guidance for this cohort of patients, and also, most importantly, to minimise the risks associated with caring for patients who have a tracheostomy. At this stage, I'd like to now hand over to my colleague Diva, who will talk about the next steps.
Thank you for having us today. So I have to start that we're sharing the same frustration in terms of getting access to the different patients' notes. We are in a community hospital. We do lots of communication with acute trust, taking patients from them and then treat the patients, lots of communication between the different disciplines, and then handing over these patients to the community. So again, communication with the community team and continuity of the care. So I joined the trust in 2015 and joined this lovely group working with the quality improvement project. I don't have time really to go through all the steps, but Hannah, my colleague, she brought a beautiful job poster that explain all the efforts that we have done through the years, through these few years. So it took the project. Initially, we're just looking at what has been done since 2014 and what we have to continue. So those who are familiar with the quality improvement project, one of the main challenges is how to sustain the good job. So starting with the looking at what has been done, what are the gaps, what need to be done further. And then, you know, again, you're probably familiar with the current NHS challenge that people, they don't stay in one place. The skilled people, they move, and that put us in a different position to train people all the time. So again, ongoing change and development in the tracheostomy management. That means that they brought neo-tracheostomy, introduced neo-tracheostomy, and then the staff needs to be trained to how to use that. We needed to look at training more staff and involving the junior doctors as well. So what we started with the champion, tracheostomy champion, which was a great job to move and train the staff in the first place. However, we noted that people leave the responsibility of a tracheostomy patient with the champion, and out of hours we are in risk. Out of hours, the staff, they have to rely on the junior doctors, and not necessarily the junior doctors have been trained enough to look after the patient with the tracheostomy. We had to ensure that the patients, staff who are involved with the care of these patients, they are familiar with the tracheostomies, new development in tracheostomies, and we used to rely on outside resources, specialist nurse coming from the other hospitals for the specialist input. Then that was, we felt that that's probably is a weakness for us, and we had to come with some strategy to improve our services. The other thing was looking at our documentation and tracheostomy tube care. So we, the first few months, we look at mainly on our incidents form, listen to our staff, looking on the concerns. We did some root cause analysis to look at what exactly could go wrong, specifically out of hours. We came up to 5 main areas to look standardizing the weaning process, clinical approach, documentation, increasing the nurse involvement, and looking and going through all the incidents related to the tracheostomies. We look at the infection, look at the compromising airways, and the monitoring, so not only the patients, but equipment, staff training, competency and compliance with the training. One of the main responsibility for our staff is to look at the discharging patient to the community. So the patient we are talking, they are very disabled patient, neurologically impaired, so we have to look at how we could reduce the risk, integrate this patient to the community, looking at the community access and community follow-up. So it's the list of the different intervention, and one of the earliest intervention we introduced a tracheostomy weekly ward round, and that basically becomes as a heart of our intervention. It brought all the discipline together. So we had this weekly ward round. We had a speech therapist to attend this ward round, doctors, junior doctors, nurses, and the physiotherapist, and we look at the tracheostomy. We developed this template, so it prompts us to look at all aspects of the patient's care. We look at the patient's bedside, patient's communication, looking at the equipment, monitoring, documentation, and basically this led to the following interventions. We look at the further training for the nurses, further introduce some checklist for community access. So these patients, as part of the rehabilitation, we would like to integrate them to the community. So we look at what equipment they require when they go for the community access, and to making sure that all the safety checklist has been done. So lots of new template. We developed lots of new templates. In the meantime, lots of audit tools has been provided to making sure that all these intervention is audited. We get a feedback, we record that, and then we improve it as we go. So in the meantime, we were meeting every 6 weeks with the Tracheostomy Care group, looking at updating our tracheostomy policy. We managed to get funding for a band 6 staff nurse to coordinate looking at at staff competency, educating and training the nursing staff, and also liaising with the outside specialist nurses and some further training for the staff. We got our training around the junior doctors turnover, so every rotation we train our junior doctors in management of the tracheostomy, emergency management, and looking at how we could engage them more. I have some specific session for quality improvement project for the training for junior doctors, so that engage them more in managing the trachea. Our staff nurse, she introduced some drop-in session, which asked the nursing staff and the other therapists and junior doctors to drop in for further training and checking the competency, and some hands-on session to look at that, the understanding of the trachea. So we trying to change the culture of the ward. So the champion is not only person who is responsible for the tracheostomy patients, everybody's responsibility, and it needs to be everybody's responsibility to raise if there is any gap. So this is a picture of the ward, one of the Hannah's training session. We introduced some visual prompt card in a bedside to making sure the trolley is set as it should be and all the equipment is available. We introduced some new tracheostomy care checklist. So, for example, one of the template that we had for a weekly ward run, we noticed that not enough information has been monitored over the time, so that's led to the further checklist. Again, checklist for the patient when they discharge the patient with the tracheostomy to reduce risk of the tracheostomy airway, compromised airway or tracheostomy complication. So it wasn't easy to do. So when I was doing some study on a quality improvement project, I remember I read somewhere that the more people you involve in your project, the better the outcome. But I have to say that it's not always like that. So the more people you involve, you get more conflicting opinion, and it's not always easy to do that. However, I had the pleasure working with a nice team that they managed to these opinion and they find always the way to progress to the goals that we wanted to achieve. Workforce shortage has been always a problem. We train staff, we train junior doctors, but it's not always easy to keep the staff. I'll pass it to Rehab to tell you a little bit about how we tackle these challenges.
Okay, thank you. I think a lot of the challenges and things that we discovered that we had issues with have already been addressed today in terms of processes, systems, and communication. But we've just prioritised a couple of top tips, and we thought we'd like to go over these. So it was imperative to make sure that core staff were actually involved in the whole process, but wider multidisciplinary teams from clinicians to AHPs, nurses, and healthcare professionals, and to be open to their constraints within their own disciplines, and how do we work with those, and how do we negotiate their timescales to make sure that their views are incorporated into there, ensuring that all staff are aware that they have a duty of care for safe tracheostomy management, and actually once again prompting and reinforcing staff to ask questions about things they didn't know and about things that they did know, so we can validate what was going on and what was actually correct and reinforce it that way. Using effective communication and interpersonal skills, and going back to effective communication, I think it became quite evident that we had to sort of use an operational definition in terms of what was effective communication within the context of what we were doing, rather than generalizing that a little bit. And using latest evidence to actually get best practice, encouraging and facilitating healthy discussions where there were conflicts of opinions. So that worked really well, and actually critiquing the evidence and allowing people to do that, and promoting team working and a positive culture within the ward. Identifying knowledge and competencies and skills sets required and the current gaps and addressing those, so providing opportunities and education, professional development of teams, so providing implicit learning through the introduction of junior staff members, as well as explicit learning through engagement in meetings and making sure that they were involved in all the protocols and new ways of working, and then considering carefully how to implement changes within the workforce, identifying dedicated resources where necessary, and actually remembering that people actually don't mind change, people mind being changed. So that was really important from a communication point of view, and actually getting people involved in doing all those things, and also reminding people not to abdicate their responsibility, going back to what Deepa said, that we all have a duty of care and responsibility to make sure we mitigate any risk for patient safety. Monitoring impact of change and optimising any resources, and considering how to sustain in the longer term. So for example, staff that are on rotation, as our complexity of our patients actually increases and we're expected to do more for less, how do we manage that? And adhering to local and national guidelines. Okay.